Hello, everyone, and welcome to today's webinar in the Public Health Webinar Series on blood disorders. This webinar is presented by the Division of Blood Disorders at the U.S. Centers for Disease Control and Prevention, also known as the CDC. I'm Dr. Poonam Malik, and I'm a professor of pediatrics and a hematologist-oncologist. I direct the Comprehensive Sickle Cell Program at Cincinnati Children's Hospital. I also serve as the program leader in Hematology and Gene Therapy program, and I'm the Marjorie J. Johnson Chair in Gene and Cell Therapy at Cincinnati Children's. I'm delighted to be with you to moderate today's webinar, exploring the important topic of bone marrow transplantation and other curative approaches to thalassemia. Before I introduce our guest speaker, I'd like to go over a few points for joining this webinar. Upon joining the webinar, you will see two audio options. You can opt to listen via the speakers on your laptop or by using your phone to call in. If the phone option is chosen, the webinar tool will provide you with the phone and access number and audio pin. All audio will be muted. At the end of the presentation, there will be time for questions. To submit a written question, please use questions area of your toolbar. The presenters will respond to as many questions as the time allows. Today's webinar will last approximately 1 hour. Please note that this webinar will be recorded. We will begin today's webinar with two brief audience polls. First, we are interested in knowing more about you. So please select your response to the poll questions now. That's great. We're collecting responses, and I'll give a minute or two for the polls to collect all responses. That's great. We have a very diverse audience. Thank you. So it seems like we have a lot of healthcare providers, public health professionals, and persons with thalassemia, some community-based organizations and industry partners. So welcome. We'll have a second audience poll question to know where all of you are calling in from. I'll just wait for a minute for all the polls to come in. That's great. So the majority of people we have are from North America, but I would like to welcome all our international viewers of this webinar. Welcome, and thank you for calling in from so far away. With that, I would like to now introduce our speaker, Dr. Thompson. It is my pleasure to introduce her. Dr. Alexis Thompson is a world-renowned expert in hemoglobinopathies. She's the head of the hematology section of the Division of Hematology, Oncology, Transplantation at the Ann and Robert Lurie Children's Hospital of Chicago. She's also the Associate Director of Equity and Minority Health at Northwestern University. I'm very excited to hear her talk today on bone marrow transplantation and other curative options to thalassemia. Dr. Thompson, welcome, and let's begin.
Dr. Malik, thanks so much for the kind introduction, and it's really my pleasure to participate in this webinar series. There's so many exciting things happening right now in this particular space in stem cell transplantation and gene therapy. So it's my pleasure to present our current findings. And these are my disclosures. I hope to cover progress in transplantation and gene therapy in beta thalassemia, to talk about the experience in transplantation and alpha thalassemia, and also to touch on some emerging approaches to cure. Now, I think some of the audience may be familiar with some of these approaches to potential cures for thalassemia. They include hematopoietic stem cell transplantation, which can be allogeneic related matched sibling donors usually, allogeneic from unrelated donor stem cell sources, or haploidentical transplants. When we think about gene therapy is a terminology that can be applied broadly. And so the term gene therapy can be used to apply to gene addition, gene editing, and base editing. And I'll touch on all three of these today. There are a number of factors that one needs to consider in thinking about transplant as it relates to the outcomes. First and foremost is the severity of thalassemia complications prior to transplantation. Probably the best example of that is iron overload. And so to the extent that patients don't have iron overload or have iron loading that is well controlled with chelation, that they are bound to have better transplant outcomes. Outcomes are different based on stem cell sources, whether it is marrow, peripheral blood, or umbilical cord blood, and the availability of the type of donor. So when there is a sibling donor, we'll look at some of the results compared to that, but also with alternate donors, and then also ones that are either partially mismatched or match unrelated. Preparative regimens also affect transplant outcomes, as does age and iron status. Today, stem cell transplantation with a matched sibling donor should be considered standard of care for beta thalassemia. Risk has now been stratified, and it's so important to think about things like the adequacy of chelation, liver enlargement or hepatomegaly, and also the presence of hepatic fibrosis. These last two categories are often a function of the degree of iron or liver injury, either from iron or for infectious diseases such as HIV and hepatitis C. Also, we know that we can actually modulate the adverse impact of those particular factors by intensifying the conditioning regimen for these high-risk patients. But overall, the survival and the event-free survival for beta thalassemia when a sibling donor is identified make it so favorable that this is now the standard of care. As I've already mentioned, age, existing organ toxicity can impact outcomes, as well as the choice of myeloablative versus reduced intensity conditioning. This slide summarizes outcomes for sibling donor transplants, and what the important takeaways are that if one is going to pursue this transplant, the best outcomes are in children who are relatively young, less than 7 years of age, and those that do not have evidence of liver injury, and so do not have hepatomegaly. But certainly as one goes up in age, and if their thalassemia is associated with hepatomegaly, the outcomes are less good. Now, there are a number of considerations when we think about transplantation for thalassemia, as well as a related condition, sickle cell disease. And that is today, most patients will lack a suitable related sibling donor, and in many cases, an unrelated stem cell donor. There are open research studies for unrelated donor transplants, and also those with a reduced intensity or for haploidentical donors, which many patients would be interested in hearing more about. And at the end of my talk, I will certainly direct you to where you would find these research studies. But allogeneic transplants are associated with a number of potential complications, including non-engraftment or graft failure, infections, especially during the period of time where individuals are immunosuppressed or have had myeloablation. Graft versus host disease can occur with allogeneic transplants, infertility, and then a risk for transplant-related mortality. But again, beginning with knowing what these risks are and beginning with the observation that many individuals won't have a suitable allogeneic donor, This has led to interest in gene therapy, where the patient serves as their own donor. And gene therapy right now falls into a number of categories. I'm going to talk to you primarily about gene addition. It's because that approach in beta thalassemia is the approach for which we have the most clinical data. In thalassemia, gene addition typically would add a normal beta globin gene. However, it leaves the patient's own native gene intact. And in thalassemia, our goal would be to reduce and perhaps eliminate transfusion dependence. We can also attack beta thalassemia by modifying the expression of other genes that play a role in the disease phenotype. And this can be done by gene addition or by gene editing. And in doing so, we alter the expression of genes that typically regulate fetal globin. There's also an interest in looking at some other approaches, but that one seems to be the one that we have the greatest amount of clinical data. And again, this is either gene addition or gene editing. And then I'll show you an approach that's quite interesting, looking at potential direct correction of thalassemia mutations. This slide shows a cartoon of a variety of different vectors that have been used or are currently being used in clinical trials for sickle cell disease or thalassemia. This cartoon actually shows some of the basic components of lentiviral vectors that are being used for gene addition. The lentiviral vector most commonly used is a heavily modified HIV-1 lentiviral vector. And in red, you will see that the most important thing is the gene that the gene addition is delivering, most often a beta globin gene, but at least in one case, there is a modified gamma globin gene under the control of the locus control region that is of the normal regulatory mechanism of globin in our red cells. I'm going to focus a little bit more on lentiglobin BB305. This is a replication defective self-inactivating lentiviral vector that has the human beta globin gene that contains a specific modification called beta A T87Q and is under the control of the beta locus control region, which would make it red cell specific. The amino acid substitution T87Q in the setting of sickle cell disease would inhibit polymerization of sickle globin. But in the case of thalassemia, its other advantage, it allows us to identify the transgene globin levels in the patient's blood, in the peripheral blood, by a technique called HPLC. And so I can monitor with a blood test the presence of beta A T87Q that would be distinct from the beta A that would be from transfused red cells from the blood bank. And it would also be different than beta E for patients who have E thalassemia, or in the case of sickle cell, beta S. And so this particular marker has a number of uses. This is an overview of the lentiglobin gene therapy program, and I will preface this by saying that this approach is one that has now been replicated in most gene therapy programs. The patients, after being screened and found to be eligible for gene therapy, will undergo mobilization of their stem cells using a combination of two medications, G-CSF and plerixafor, which will mobilize stem cells from the bone marrow into the peripheral blood and allow collection using a machine called apheresis. Those cells are then modified, and most of the time in the lentiglobin programs, this requires shipment of these cells to a central manufacturing facility where they are CD34 selected or purified to identify the specific stem cells of interest. They are transduced with the lentiviral vector, which will introduce that vector into the patient's stem cells, and then this product is frozen. The patient, in the meantime, has gone home and has gone about their business, and then they are readmitted where they are given a preparatory treatment with busulfan for myeloablation over 4 days, and then allowed a few days of rest. Then these frozen cells, which have been shipped back to their local hospital, are then infused. The patient remains hospitalized until we show evidence that these infused stem cells that now contain the lentiglobin BB305 are functioning, and then patients are monitored primarily as outpatients for a total of 2 years, during which time we hope to see gene therapy-derived production of hemoglobin A T87Q. Patients are also asked to participate in a long-term follow-up study for a total of 15 years. This is data that was published a few years ago in the early cohort of patients from the international HGB-204 trial and the French HGB-205 trial. And this plot looks at in the lighter shaded areas, a period of time when the patients were still requiring transfusion support, and the more intense or darker bars represent the period of time over which the patients have stopped being transfused. And you will see that for most patients, they were able to stop transfusions within 6 months of the product infusion, and that by and large, they remain transfusion independent. This next slide shows that most of the hemoglobin that they make in red is a hemoglobin T87Q, which pushes these patients up to a hemoglobin that most patients would find tolerable and certainly is adequate to make them transfusion independent. And it's in this study, it's out to 60 months. I will tell you that patients are now far farther than just 60 months. And that's shown in this next slide. And this is looking at the durability of the patients now that we're seeing them in the long-term follow-up study. And you will see that for the phase 1-2 trial, the one that I showed you in the last few slides, those patients again remain independent. We've made some modifications which we believe are improvements in the process, primarily in the phase 3 trials. And so there's shorter follow-up. But I think what you will notice is that the patients are becoming transfusion independent faster. And when you look in this column here, that their total hemoglobins are higher. So not requiring transfusions and now having near normal total hemoglobin levels. There's also some very interesting work that's come from our colleagues in Northern Italy, the phase 1, phase 2 trials using a different lentiviral vector called GLOBE. And in the GLOBE trials, there are 2 distinctions. The vector is different, and so the insert is slightly different. But one important innovation, it was intrabone administration of the hematopoietic stem cells. So while in the lentiglobin BB305 experience, the stem cells were returned to the patient into a vein, and those cells would travel back to the bone marrow. In the GLOBE experience, they actually injected the stem cells directly into the marrow space itself. And the reason for that was to avoid the potential loss of some stem cells that might get hung up in other organs like the spleen or the lungs. But they also were looking for the impact of infusion on transfusion dependence. The adult patients that were treated, there were 3 of them, had a reduction in their transfusion requirement. 4 children were also treated on the GLOBE study, and 3 of the 4 had enough improvement to become transfusion independent with improvement in effective erythropoiesis. I'm going to pivot to talk about gene editing, which also requires stem cells being collected from the patient's body and then being modified in the laboratory. But in this case, instead of having gene addition, it undergoes gene editing, and then these corrected cells are returned to the patient's body. The most common platform that's being used for gene editing is CRISPR-Cas9. And this summarizes the experience in the CTX001 trial that targets BCL11A, which is a transcription factor that is so important for the suppression of fetal globin that would occur normally after birth. And so during fetal development, babies primarily depend upon hemoglobin F, and they have alpha globin and gamma globin on. But somewhere just prior to delivery, gamma globin turns off and beta globin turns on, and BCL11 is responsible for that. Now, in the setting of thalassemia, this beta globin is abnormal and defective and will not produce enough hemoglobin. And so these investigators asked the question, what if I left this gamma globin on and allowed it to continue on? Well, with this approach of gene editing, they actually disrupt an erythroid enhancer for BCL11A. And this allows BCL11 to become silent and allow gamma globin to return back on. And so these studies are asking the question, with this approach, can we actually get sufficient gamma globin production to make enough hemoglobin F for there to be clinical benefit? This is a paper from the New England Journal of Medicine that examines the first patient with thalassemia, who was patient 1, and the first patient with sickle cell, who is patient 2, who have undergone gene editing using this approach. And what you will see for patient 1 is that they began gene therapy with primarily hemoglobin A from the blood bank, but that within a few months of undergoing gene editing, they no longer were receiving transfusions, and so the effect of those transfusions in green went down. But you see the reemergence of fetal hemoglobin. So now that we've silenced BCL11A, this individual was able to make increasing amounts of fetal globin, such that by 12 to 15 months, they're making primarily hemoglobin F with the hemoglobin A from the blood bank leaving their body and them having a near normal total hemoglobin, or a normal, I should say, total hemoglobin. What's most important also is to actually not only see it over time, but to see it in more people. So this is actually the results that have been, since the publication of the New England Journal, now of a total of 7 individuals with thalassemia who have undergone the gene editing as part of the CTX001 study. And what you can see is those individuals are having similar results, with becoming transfusion independent within 6 months, and then having normal hemoglobin levels that are almost entirely hemoglobin F that result now from BCL11A silencing. There are risks of all types of gene therapy, so both with gene addition as well as gene editing. Many of those are related to the current approach for conditioning with busulfan. They include mouth sores and hair loss, which occur very early in the process while the patient's in the hospital, and also the risk of a very unique complication called veno-occlusive disease, which is an inflammation of the liver that results in blockage of bile ducts, which can be treated and or prevented with current medications. There's also a risk for graft failure, although fortunately it has not been seen in the current clinical experience. But for many clinical trials, a set of unmodified cells are stored, are frozen in unmodified form in the event that graft failure occurs, so that patients could actually be safely recover. Clonal dominance or insertional oncogenesis is a particular consideration for gene addition using lentiviral vectors. To date, there has been no cancer risks or clonal dominance that has occurred, but it is certainly a risk. Off target is a risk associated with gene editing, and busulfan is certainly known to cause sterility and infertility. I'm going to pivot to talk about alpha thalassemia. Alpha thalassemia is caused by many different mutations that occur in the alpha globin genes that are located on chromosome 16. And they are a pair of alpha 1 and alpha 2 genes. And as you can see, many of the mutations, and these are just cartoons of the mutations that are in these bars, occur, and they wipe out both alpha 1 and alpha 2. They also wipe out something called zeta, but not all of them. And I bring your attention to a number of the mutations, the most common of which is called SEA, or Southeast Asian, and Mediterranean type 1, that certainly will impact both alpha 1 and alpha 2, but leave zeta intact. And that actually is something that, that we want to pay attention to, because it may pave the way for a potential treatments. When we see beta thalass or alpha thalassemia, again, SCA or Southeast Asia is the most common mutation. It's very large, but it leaves the zeta hemoglobin gene intact. And so as a consequence, babies may be able to survive, just barely, but survive without intrauterine transfusions into the 3rd trimester. Other common mutations, such as the Filipino and the Thai mutations, are far more severe, and survival is dependent upon perhaps it being co-inherited with a mutation like SCA. This same kind of scenario affects people of Mediterranean descent from Greece and Sardinia. Now, the International Registry for Hemoglobin Barrett's Hydrops Fatalis has been a wonderful resource that a number of my colleagues around the globe have contributed to. And there are now a total of 69 cases in this international registry from 13 countries. And nearly all of the individuals in the registry are transfusion dependent. Of that 69 cases, 18 have now moved on to stem cell transplant. And of those 18, 14 are now transfusion independent. And this is a summary of previously published and unpublished cases, but I turn your attention to the publication of the published cases. Alpha thalassemia transplant outcomes are typically better if the transplants are performed early, ideally with a matched sibling donor, although some of these transplants were using mismatched donors that were related but not siblings, and then unrelated donor sources. Some of these individuals had complications which are known to be associated with transplants, such as graft versus host disease and PTLD. But of these 18 patients that have been transplanted, there were 4 that were not successful, and the patients died. One died, and 3 had graft rejection. But many were still known to have poor growth in 4 of the 10 patients who underwent transplant. And this once again speaks to the benefit of early transplantation, where there is more of a possibility of recouping this loss in growth potential. I'm going to speak briefly about some emerging approaches. Now, I've mentioned a number of complications associated with busulfan, including the risk of cancer and infertility. So there is a tremendous interest in looking for alternatives to busulfan, but still seeing the successes that we've seen thus far. These include looking at non-genotoxic approaches to conditioning, and also reduced intensity or the use of drugs other than busulfan, using something like treosulfan to hopefully retain some fertility. I will tell you that there are no such approaches today for gene editing, but there are for gene therapy in Europe, and also for standard conventional transplants, for allogeneic transplants as well. But the early non-genotypic approaches are currently in clinical trials for immunodeficiencies in cancer. We're looking forward to gaining from what those investigators are learning, and to see whether or not some of the non-genotoxic approaches can be applied to thalassemia. I want to share with you, in the meantime, some new approaches to thalassemia using direct gene correction. This is a paper that was published from Matt Porteus's group at Stanford as a proof of concept, looking at the possibility of using whole gene replacement using Cas9 AAV6 mediated gene correction, where a full-length beta globin transgene is actually inserted into the locus for alpha-1 on chromosome 16. These investigators were able to show that this very novel approach can normalize production of the beta-alpha globin ratio, and can actually get quite good globin production. And so this is a proof of concept of a very novel therapy. There's also questions about whether alpha thalassemia can be approached this way. Now, direct gene correction is going to be challenging, in part because the deletions are quite large, and also because of the variations of them. And so whether or not we can actually do gene addition remains to be seen. Having said that, one of the other questions is whether we can alter the expression of a gene that might regulate the embryonic genes. And so that zeta gene that I mentioned before is in the embryonic gene. And so could this be something like the BCL11A approach that is currently in clinical trials for beta globin? There seems to be at least some early data to suggest that you can reactivate the embryonic genes. The question is can you actually reactivate these and to get high enough expression to make sure that this is something that will actually have the long-term benefit that we hope that it will have. In the meantime, there's some very early preclinical data looking at gene editing using CRISPR-Cas9 to correct a specific type of alpha thalassemia major called hemoglobin H constant spring. I've mentioned to you almost all of the work that I've done has been in the clinical trial space. By and large, it's only in Europe that gene therapy for thalassemia has received approval. But for other clinical trials that are evolving, I turn your attention to some resources for learning more information about clinical trials. The Library of Medicine site, clinicaltrials.gov, remains a very important resource for looking for information. This is open to the general public. The Thalassemia Foundation and the Thalassemia International Federation are also important resources to have questions answered from both providers and patients about gene therapy, about stem cell transplant, and about thalassemia and the best ways to care for oneself as these curative therapies continue to evolve. So in summary, we've made progress in thalassemia management, which expanded the lifespan, but many disease and treatment-related complications are still significant sources of morbidity. Early gene therapies results are promising and may provide cures and should be investigated further in a research setting. Outcomes with postnatal transplant and alpha thalassemia are sufficiently good to consider this option regardless of the donor source. And though experience is really very limited, most patients with alpha thalassemia who undergo stem cell transplant will engraft with the donor stem cells and will become transfusion independent. I also share with you some recent advances in research that hopefully will identify additional targets for new, potentially curative approaches. But there are still some questions. Will this single infusion, which is the current approach for all types of gene therapy as well as stem cell transplant, will it be durable and will it be lifelong? Are there additional modifications that we can do to reduce the risk? Will the results be better in younger patients who perhaps have less organ injury? Given that there are so many approaches that are currently being undertaken around the world, will the results be different using, for instance, different vectors or different gene editing approaches? And will gene editing achieve similar or superior results when we think about gene addition? I look forward to this field continuing to evolve. In the meantime, I'd like to thank you for your participation today, and we are now ready for questions and answers. And so I'll turn the mic back over to my colleague, Dr. Malik. Thank you.
Thank you, Dr. Thompson, for this excellent talk. And I think that your talk has already inspired a lot of questions. So I'm going to just try and see how I can group these questions together. So I think the first question, there are a couple questions regarding beta P87Q, whether it inhibits sickling or polymerization, sickle hemoglobin polymerization better than fetal hemoglobin. And a related question is that, is HbF inferior to hemoglobin A in adults? So if you could just address the question of hemoglobin A, hemoglobin F, or fetal globin, and the beta 87 version of beta globin in correcting thalassemia, that would be great.
So thank you for both questions. So I didn't want to digress too far, but I will tell you that hemoglobin, the T87Q mutation in beta globin happens to also be a native sequence in gamma globin. And so it's not surprising that the that there would be benefits to T87Q in the setting of sickle cell because certainly that makes that gamma globin, that beta globin look more gamma-like. In both instances, both beta globin and fetal globin are capable of carrying oxygen, although we had this natural switch for a reason. And so certainly the propensity for fetal globin to hold on to oxygen, has sort of always raised the questions about tissue delivery. Having said that, the natural experiment are individuals who have hereditary persistence of fetal globin, and these patients are remarkably well. And so I think that has led to great reassurance among investigators that perhaps having exclusively fetal hemoglobin is a fine substitute for beta globin for individuals who are able to make fetal globin. Now, having said that, in both the setting of lentiglobin or CRISPR-Cas9, the ability to make new globin and have it being near pancellular, so that nearly all of the stem cells are now making it, and not just a fraction of those cells. That aspect is a common feature for all of these approaches. And so looking at pancellular expression, whether it is T87Q or it is de-repressed fetal globin because of gamma being produced, that has to be an important feature. So I believe that they are different, but that is not surprising that they actually both will have some benefit. I think that we are not at a point yet, however, where we're ready to compare these two approaches head to head. There need to be more patients that are followed for longer for all of these different approaches. But I do think that there are certainly some very unique challenges, as well as some benefits that we are seeing from these two approaches. I'm just thrilled to see this evolve and to see in general thalassemia patients doing so well with gene therapy.
Thank you. So there's another question from one of our patients, I believe. Is there a certain age range that is recommended for stem cell transplantation? I know you've answered that in one of your slides. This question came early on.
I think that's a great question, though, because some people sort of, is it too late for me? And the answer usually is no. It does depend upon the general health of an individual. And so even if it is someone who is a late teenager or an early adult, as long as they don't have evidence of organ injury, which may not be reversible and that may make their transplant more complicated, they can and should talk to their physician about being considered for curative therapy. As I pointed out, however, in my talk, patients who are under the age of 7, who have a sibling donor, who don't have evidence of organ injury, are going to be those individuals who do best with matched sibling donors. In the era of gene editing and gene therapies, we now have patients that are down below the age of 5 who have undergone these procedures. They've also done quite well. And so the notion about safety and these younger patients, I believe we're gaining more and more information, but our early experience suggests that these younger patients do quite well. Now, the oldest patients with thalassemia that have undergone transplants are in their 30s, and the same is true for gene therapy. So we can at least say with confidence that for thalassemia, that patients into their 30s will do very well. We know that for transplants of all kinds of conditions, that patients can be transplanted as they get older, even into their 50s and 60s. We just simply don't have that experience with gene therapy for thalassemia.
Great, thank you. We have a question from Sanjay Dhar. When do you expect Bluebird Bio's gene therapy product to be a safe option? And the same person is asking, do you think gene addition or gene editing will be a better option? Better option to cure thalassemia?
So when you're asking me, when do I think it will be a safe option? If you're asking me what I think is going to be a safe option, the answer to that is now. If you're asking me when it will be a commercially available product, that is a different question. And I will dare say that one is much more complex because it certainly does require the approval of regulatory agencies, so the Food and Drug Administration in the United States and the EMA in Europe. I do think that that process that the data that has been collected thus far is I must say, personally, is fairly robust and reasonably convincing. But having said that, I do believe that that there is movement with going through that process. I am fairly certain that Bluebird updates its information on its website for its plans for its commercial program. But I certainly am looking forward to a point in time where patients can be offered this, not just on a research basis, but as therapy.
Yeah, and a similar related question is that there is Muhammad Ashraful Raihan is asking whether these are approved or in clinical trials, and they're obviously in clinical trials yet. But if these were approved treatments, when would these be available for Asian people?
To be clear, the beta thalassemia program has been approved in Europe. And so it's under the brand name Zynteglo. And so it actually is available commercially in Europe. There has been a hold on the program in Europe, which one can only hope will be lifted sometime soon. That's related to toxicities that we're seeing in some patients in the United States on a sickle cell research study. But commercially, it has been approved. We're waiting to see whether the regulatory agencies in Europe are satisfied, as the FDA has been, in lifting the hold for the commercial use of it in Europe. But it is not commercially available in the United States. My assumption is that once all of the concerns or questions have been satisfied, that there will be an opportunity for more countries globally to examine their interest in having gene therapy made available to people in their country.
Thank you. I have another question from Israr. It seems to be a parent of a patient with thalassemia. I'm not very clear on this question, so I'm just going to read you verbatim. My 2.5 years baby need to do stem cells as I preserve the stem cells of my second child, but not yet declare as free of thalassemia. Can you please tell me still the stem cell can be used? So I'm gathering that. Sorry,
assuming
go ahead.
that we're asking me about the cord blood, whether or not the sibling is free of thalassemia. I think that that's an important and an absolute critical question. Certainly, even if the potential sibling donor has trait, there are many individuals who have had sibling transplants from siblings who were tissue type matched but have thalassemia trait, and the recipient has done just fine. And so certainly the possibility, certainly you would not use a cord blood from someone who actually has thalassemia. The thalassemia trait is just fine. I do think that there are other considerations, like the number of stem cells that were collected in the process of obtaining the umbilical cord blood cells. There are circumstances where the absolute number of cells that were in the cord blood unit are not sufficient alone to achieve a cure with a transplant. And in those circumstances, the children are given not only the cord blood, but they may also need to be supplemented with bone marrow. And if that is the case, that certainly requires much more advanced discussions with a stem cell transplant team, and to understand what the risks are and what is the minimum age at which they would subject a donor, a healthy donor child, to, for instance, a bone marrow harvest or apheresis to collect stem cells. And so these are fantastic questions. They really should be discussed with a transplant specialist in your area.
So, Alexis, thank you. We have a lot of questions, so I'm going to speed through some of them now. One of the questions by Tanya Baer is, what is off-targeting?
Great question. So when I showed this cartoon of CRISPR-Cas9 gene editing, that is a cartoon, and that this is the best case scenario, that when we actually put this enzyme system into the patient's cells, that it only corrects exactly what we want. And that, by and large, is what predominantly happens. The question is what if there is a sequence that looks similar? Not the same, but similar. Is there any potential for the correction to involve sequences that look similar to the site in the enhancer of BCL11A? And in theory, the answer is yes. Now, we do have assays that will allow us to pick that up. And in the current setting, the events that are occurring that we call off target, because the target was beta globin, so anything, was BCL11A. So anything that was not BCL11A would be considered off target. Fortunately, the early experience suggests that in the clinical setting, we have minimized the risk of off-target events. But it certainly has occurred in the laboratory setting and in animal models. And so we would be remiss if we did not continue to add that as a potential risk in humans, just because of the nature of the kind of correction.
Thank you. So there is another question. Are there a chance to us as clinical hematologists to get practical training courses on gene therapy for thalassemia in USA or other countries? And this is Mohammed, I'm sorry, I'm butchering this name, Dwashahid, who also wants to thank you for all the efforts you're putting in.
What I would say is that there is not, it's probably not a one size fits all in terms of there being a single site that is available to have someone learn all aspects of this. I would say certainly for my own site, it is truly team science. It really requires a wide array of investigators as well as clinical team members. And it takes a tremendous amount of investment to have all of that team gathered and to actually identify all of the resources that are important. And so while I would love to say that we're at a day where we could actually have someone come and learn in a very limited period of time to be able to take this technology to another country, I will be perfectly honest with you, I think that we are not there yet. I think that it would be quite challenging to think that we could actually do that today. But certainly, given the global impact of thalassemia as well as sickle cell, being able to offer this to patients worldwide is absolutely a goal, but we're just not there.
Thank you. Is chemo necessary? Is chemo a necessary part of CRISPR study as well? This question is from Sylvia Beva.
The answer is yes. And chemotherapy serves two purposes. If you can imagine, its principal purpose is to simply make room for these modified stem cells. And so people with thalassemia have bone marrows that are packed full of blood-forming cells. And so we actually have to make space for these corrected cells to actually engraft or to find their way to the marrow and then sit down and make themselves at home. We also need to get rid of the cells that have not been corrected. The reason for that is because if we did not do that, the patient's own native cells would overgrow these newer corrected cells. And so we want to minimize the number of unmodified cells and in general make space for these new cells to sit down. And today, the most successful approaches continue to require chemotherapy. even though chemotherapy is associated with these risks that I've already described. Clearly, the best approach is only fix what is broken. And so in the future, if we can just deplete the stem cells and make enough space for these new stem cells to come back in, that certainly would be the goal, but we are not there today in thalassemia.
So thank you. The next question is, are gene therapy trials only for transfusion-dependent patients?
Today, the answer is yes. And I think that what that reflects is that we know that by and large, these are the more severely impacted patients. And so conventionally, we often think about the risks that are associated with any procedure against the potential benefits of those procedures. And so those patients who have higher risk disease are certainly likely to have the greatest benefit from these kinds of procedures. As these procedures become safer, as they become more widely available, I do think that there will become a time when it is worth asking the question whether or not a non-transfusion dependent thalassemia patient would also benefit. That's not today, but I do think that there might become a point in time where we are in a position to ask just that question.
Thank you. And now we have another question from Basim Haneen. What is the best approach for major beta thalassemia to reduce the side effects and infertility?
So, and I'm assuming you're asking me about all kinds of transplants. And so, for instance, that question, it depends in a lot of ways. Certainly, if I'm looking at an adult patient or at least a teenage patient, we aren't able to mitigate that risk sufficiently and still ensure success of the transplant procedure. And so the recommendations are doing something to preserve fertility that largely involves harvesting either eggs or sperm prior to the transplant procedure. We know from cancer experience and other medical conditions where transplant is being used that adults who have sperm or eggs harvested, that those products are capable of producing healthy children in the future. For people who are younger than or for children, I should say, who have not gone through puberty, there are research studies that would suggest that there are approaches for ovarian tissue cryopreservation and spermatic stem cell collection that may hold promise for fertility preservation, even while we're still using busulfan in younger children. There certainly is some experience with reduced intensity transplants with sibling donors where fertility is preserved. This becomes slightly more complicated in thalassemia because we know iron overload, even moderate iron overload early in life, will be associated with reduced or loss of fertility irrespective of transplantation. And so it's important this reinforces the importance of high quality care and diligence with managing your iron overload throughout the lifespan. Because if you go into a transplant with limited fertility, no matter how we modify the transplant, the likelihood of having children afterward is reduced.
Thank you. We're getting close to the end of the hour. So what is the residual degree of ineffective erythropoiesis in patients undergoing gene addition therapy or gene editing? This question is from Sujit Shet.
I think that is an outstanding question, Dr. Shet. In my assessment, I do believe that ineffective erythropoiesis persists. The question is to what degree, and can anything be done to mitigate it? We know that the ME ratio, the myeloid erythroid ratios improve. They definitely improve, but they're not entirely normal. We know that with gene addition or with gene editing, that normalizing the total hemoglobin will help, because certainly there is a relationship between persistence of ineffective erythropoiesis and the persistence of anemia. And so to the extent that we're reducing the anemia, one can only hope that over time, the ineffective erythropoiesis will improve. I think it's too early to say whether or not they will ever look exactly like patients who have undergone allogeneic stem cell transplants. I think that there is enough data at this point to say that individuals with thalassemia who have fully engrafted following sibling donor transplants, that they are cured and that their ineffective erythropoiesis has resolved.
Thank you. And I will I'm sorry we can't answer all the questions right now, but I'll just give one last question. This is from a parent who's had one child apparently have a bone marrow transplant. They have a second 15-year-old child, and they want to know whether gene therapy would be an option. Would it be better than getting a bone marrow transplant? And they are also concerned about myeloablative conditioning for 5 days. They just want to know what would be the best option. So maybe they could contact you directly for these questions, or contact their bone marrow transplant physicians, because this is quite detailed.
And I'm certainly happy to. I think that I agree with you, Dr. Malik. I think that certainly any family should absolutely look to their local resources, if at all possible, for what is available. I will certainly say briefly, however, that sibling donors, if there is a sibling donor available for a transplant, that should be the preferred approach. It should be the standard. And that we today, if there's a sibling donor, that by and large they are not eligible for these research approaches, because we feel that sibling donor transplants really are superior today, in large part because of our large global experience. We hope to make gene editing and gene therapy more safe over time, and hopefully with something other than busulfan. But I think today they are reasonably safe, and certainly I'm very pleased at the early indications about their effectiveness.
All right, so I think we will conclude. I would first like to thank Dr. Thompson for such a valuable amount of information on a topic that is so important and current for our patients with thalassemia. I thank you all for joining us. We would also like to thank our colleagues at the CDC's Division of Blood Disorders for this invitation to be with you today, and the Cooley's Anemia Foundation for hosting this webinar. Very shortly, you will receive an email asking for your feedback, so please respond with your comments. If you have additional comments about today's presentation, please contact Cynthia Sayers at csayers, CSAYERS, at cdc.gov. This webinar will be archived, and the content will soon be available at CDC's Division of Blood Disorders website, as shown on the slide. And thank you again for joining us, and have a great afternoon.